Our today's topic is immunosuppressant drugs. By definition, immunosuppressants are drugs which inhibit cellular, humoral, or both type of immune responses, majorly used in organ transplantation and autoimmune diseases. Classification: immunosuppressant drugs are classified into calcineurin inhibitors, mTOR inhibitors, anti-proliferative drugs, glucocorticoids, and biological agents. And these are the respective drugs for these respective classes. And at the bottom we have all the classification for biological agents, which are TNF alpha inhibitors, interleukin 1 receptor antagonist, interleukin 2 receptor antagonist, anti-CD3 antibody, and polyclonal antibodies. To understand how immunosuppressant drugs work, firstly we have to understand how humoral and cell mediated immune response works. Here I am telling these both responses in brief. Firstly, the antigen presenting cells, which are coupled with major histocompatibility complex proteins, present their antigens to CD4 helper cells, which are activated by interleukins 1. In second, we have B cell, which when bind to antigen proceed to proliferation, which means a rapid increase in number, and then differentiation, leading to production of antibodies. When these CD4 helper cells are activated into activated helper T cells by interleukin 2, cytokines are produced. These cytokines increase the process of proliferation and differentiation, leading to formation of antigen antibody complex, which show the response of humoral immunity. In the later half of the page, we have cell mediated immune response, in which a complex form of precursor cytotoxic lymphocytes, which are activated by the action of interleukins 2, then matures into mature CTL, and then these CTL binds to foreign cell and leads to the death of foreign cell, that is cell lysis. Now in this video I will be explaining the pharmacology of cyclosporine, which is a drug belonging to the class of calcineurin inhibitors. It is a cyclic polypeptide with 11 amino acids obtained from a fungus and introduced in 1977. It is a highly selective immunosuppressant which increases success of organ transplants. Pharmacology. First is mechanism of action. In this diagram we have a helper T cell, and there is on the right hand side macrophage antigen presenting cell. Macrophage APC is coupled with the molecule of MHC class 2, which bears a antigen peptide molecule, which is gonna present to the T cell receptor present on the helper T cell. Now cyclosporine enters the helper T cell and inhibits the protein calcineurin, which stops the further cascade of processes which leads to the T cell proliferation. This process is further explained in the chart. This chart shows the cascade of processes which occur inside the helper T cell. Firstly, the antigen peptide bind to the T cell receptor, which phosphorylates phospholipase C molecules, which hydrolyzes PIP2, leading to the generation of DAG and IP3. IP3 stimulates intracellular calcium. Calcium binds to calmodulin, activating calcineurin, which is inhibited by the cyclosporine. Triggers dephosphorylation of NF80, which is nuclear factor of activated T cell, production of IL-2. IL-2 binds to IL-2 receptor, T cell multiplication and differentiation. All the processes following the activation of calcineurin are inhibited by the drug cyclosporine. At the top we have the uses of cyclosporine. Cyclosporine is a highly effective drug for prevention of graft rejection reaction. It is the standard drug for use in renal, hepatic, cardiac, bone marrow and other transplants. Cyclosporine selectively suppresses CMI, that is cell mediated immunity, prevents graft rejection and leaves enough immune action to fight against basic bacterial infection. If graft rejection start to occur, then cyclosporine can be given through intravenous route because cyclosporine's oral bioavailability is low. Cyclosporine is a second-line drug to other immunosuppressants in autoimmune diseases. On the left bottom side, we have all the adverse effects of the cyclosporine drug. From this, the main side effect is nephrotoxicity. In drug interactions, cyclosporins interact with aminoglycoside vancomycin, which increases cyclosporine toxicity in the body. Phenytoin phenobarbital lowers cyclosporine blood level, which can cause graft rejection. Erythromycin and ketoconazole inhibit metabolism of cyclosporine, which increases its bioavailability, causing toxicity inside the body.